Assalamualaikum and hello everyone. Welcome to this channel by me Mok. You are watching a video series about the human anatomy according to its body system. Today we are going to talk about part 2 of respiratory system. If you have not watched the first video, you can click on the link here or through the video description below. The references and credits for this video goes to Clinical Anatomy by Richard Snell, Textbook of Medical Physiology by Guyton and Hall, Complete Anatomy by 3D4 Medical, and an article by Walker et al. Previously, we have covered the airway, pleura, and respiratory muscle. So let's continue where we left off, that is the blood supply to our lung. I think most of us are quite acquainted to this topic even before learning medicine in university, because in high school biology we learn about the basic human circulatory system, and it is usually introduced as something like this, that our circulatory system is divided into systemic and pulmonary circulation. And unlike other vessels, the pulmonary artery carries deoxygenated blood to the lung, whereas the pulmonary veins carry oxygenated blood to the heart. Thus, often that when we talk about the blood supply to our lungs, we remember these parts but tend to forget one other missing component that I think is worth mentioning. According to Professor Guyton and Hall, who wrote on Textbook of Medical Physiology, our blood circulation to the lung can be divided into two types. That is the high pressure, low flow circulation, and the opposite, which is low pressure, high flow circulation, or you can put it simply, the pulmonary circulation and bronchial circulation. It is called high pressure because bronchial circulation is a part of systemic circulation, so it receives the pressure directly from the pumping of the left ventricle, which is thrice the size that of the right ventricle. Thus, the opposite is for the pulmonary circulation, which is a low-pressure circulation. And the pulmonary vessels, its arteries and veins are also thinner, more distensible, and have a larger diameter compared to their counterparts in systemic circulation. This allows them to have a larger compliance, that is, to accommodate more blood flow into their circulation without having too much change in the pressure. Its compliance are larger, so much so that it is almost similar to that of the entire systemic circulation. Let's look at the first one, the pulmonary circulation. From the heart's right ventricle, it carries the deoxygenated blood through pulmonary trunk before it branches to both right and left pulmonary artery. Note that in this picture, the pulmonary arteries and its branches are those in blue to indicate the blood that they carry, which is deoxygenated. Then both sides of the pulmonary arteries enters into the lung, closely along our bronchial tree. So you can kind of guess what their names would be if you have watched the first video where we talk about the bronchial tree. We have the lobar branches and segmental branches. So 3 lobar arteries go to the right lung and 2 lobar arteries to the left. The segmental arteries' names are also exactly the same. 3 segmentals from superior, 2 from middle, and 5 from inferior for the right lung, 4 from superior, and 5 from inferior lobar artery of the left lung. Then the artery enters into the bronchopulmonary segments and into smaller branches until it becomes the capillaries surrounding the alveoli. Gas exchange occurs here, so carbon dioxide goes out and oxygen enters. Hence, the vein will have higher content of oxygen. Unlike the pulmonary artery, the pulmonary veins do not drain from within the bronchopulmonary segment, but they are located intersegmentally. Then the segmental veins drain the blood into larger pulmonary veins. These vessels, however, do not follow our bronchial tree as much. Some of them still do. They are those from the upper half of the pulmonary veins. Let's look a bit more closer. We have the apical vein, posterior vein, and anterior vein from the right superior lobe, medial and lateral from the middle lobe. Then these vessels join together as one vessel to become the superior pulmonary vein. For those in the left lung, these are also similar. We have the 4 branches jointly drain into the left superior pulmonary vein. The first major difference you will notice is that instead of having one major trunk to each side of the lung, pulmonary arteries has a pair for each lung, which are the superior and the inferior trunk. Let's look at the right inferior branch. It branches into 2, which are the superior vein of the inferior and a common basal vein. And the common basal vein further branches into 3, which are the superior basal, anterior basal, and inferior basal. Luckily, those from the left inferior trunk are rightly similar. Throughout the pulmonary circulation, if you notice, the capillaries ended at the alveoli. So what about the rest of our bronchial tree? We certainly know from previous video that alveoli only present at the respiratory portion of our airway system, but not the conducting portion. So this is where the bronchial circulation comes in. To explain this, let's resume to where we left off just now. We already have the oxygenated blood entered into the left atrium, and then it goes into the left ventricle and out of the heart into the systemic circulation via the arch of aorta. There are a lot of branches from here onwards going superiorly, but there is a continuation of this aorta going inferiorly called the descending aorta. From here, our right and left bronchial arteries emerge. In this picture, you can see the right bronchial artery share a same trunk with the posterior intercostal artery. Actually, there's a lot of variation to this configuration. In fact, some research from cadaveric study lists up to 9 configurations. The common ones, however, according to Walker et al., are these 3. You may have a single or a pair of right bronchial arteries, and this also applies to the left bronchial arteries. The most common is to have a single right but a pair of left. But regardless of how it may present, essentially these right and left bronchial arteries then supply the conducting portion of our lung, that is the main bronchus, and up to the terminal bronchiole. It also supplies the connective tissue and our visceral pleura, which has a serous membrane where the blood transsudates through to become the pleural fluid. That fact alone is very important because it explains some pathophysiology about, for example, how pleural effusion occurs. Then the blood are drained into the bronchial veins, the right goes into the azygos and the left bronchial veins into the accessory hemiazygos, both of which eventually end up at the superior vena cava and enter into the right atrium. Whereas the pleural fluid drain back into the system through the lymphatic vessels. Finish off with blood supply, let's move on to innervation. In this section, I would like to expand this presentation not only to what innervates our lung, but as to how does our neuronal circuit looks like in its entirety pertaining to our lung function, so that not only we know what nerve there is, but in what way they serve their function. That means I'll maybe touch on to some areas which are commonly discussed in nervous system. An organ may generally specialize or falls into one of 2 categories. Either it is a sensory organ or a motor organ. But in reality, often that our organs are kind of both at the same time. Let's look some facts regarding our lung. We can control our breathing, so this reflects a voluntary control which is a somatic motor. And most of the time, we don't control our breathing. This involuntary act is also known as autonomic motor. We can cough and sneeze, so there is kind of stimulus here which bring about a change in the motor, and a stimulus stimulates a receptor which exists in the efferent pathway, so we can say that there are presence of visceral sensation as well. Some lung disease can cause chest pain. Pain is one of the type of somatosensation. And lastly, when we cry, our breathing pattern also changes. This perhaps suggests an involvement from the limbic system. Let's digest these for a while and imagine how our entire lung neuronal circuit looks like, let alone how many respiratory muscles we have and their own innervation. But let's try to organize our understanding. We can classify our nervous system into autonomic system or somatic system, although some authors like to divide them into motor system and sensory system, whichever that helps you with your understanding. But for this purpose, I prefer this classification because it helps getting my point across. In terms of motor, somatic simply means those which you can voluntarily control, whereas autonomic are those that you can't. And the autonomic is a self-regulating system where the brain receives feedback from the body regarding how it is functioning, and it detects some changes which you can't control. These feedbacks are sent by receptors which often distributed viscerally since most of our autonomic organs are located there. Whereas the somatic sensation are associated with the receptors from external organs such as the skin, joints, fascia, and the muscles. A complete neuronal circuit in general have these components. Those which forms the efferent pathway are a stimulus, a receptor, and an efferent nerve which will carry the signal to the center. An efferent pathway works oppositely, starts with a command from the center. The signal is passed via the efferent nerve to an effector organ, which then will perform an action as instructed by the brain. Let's start with the simpler system, that is the somatic system. One of the facts that we have established just now is that we can control our breathing. These voluntary control signal or command start from the primary motor center area, that is the Brodmann area 4 from precental gyrus. It is passed to all the nerves controlling our respiratory muscles. Since we have looked into them in part 1 of this video, let's just call them the efferent respiratory nerves. If you don't remember them, here's a quick reminder. The phrenic nerve to the diaphragm, intercostals to intercostal muscles, accessory nerve to the sternocleidomastoid, cervical spinal nerves to the scalene muscle, thoracic spinal nerve to the serratus, and the intercostal and subcostal to the abdominal muscles. These nerves are passed to the effector according to the muscle that they supply, so let's just call these the respiratory muscles. Lastly, they carry out action either inspiration or expiration. Then we also said that chest pain also can be caused by some lung disease. Now, how is this possible? That is because there are pain receptors at our parietal pleura, which is directly attached to the thoracic wall anteriorly and to the diaphragm inferiorly. So it shared the same somatic innervation, the intercostal nerves with the intercostal muscles and its overlying skin, and the phrenic nerve inferiorly with the diaphragm. The pain receptors send the pain signal using these nerves to the primary somatosensory center, specifically the Brodmann area 3, 1, and 2, the brain area that enable us to perceive pain among others. Now let's go to the autonomic system. As we have mentioned, this is a self-regulatory system, so the receptors that give feedback to our brain are the peripheral chemoreceptors, which are sensitive to the oxygen, carbon dioxide, and hydrogen ions. They are also known as glomus cells, which are located at the carotid and aorta. Thus, they are also known as the carotid bodies or aortic bodies respectively. These receptors then send signals via the glossopharyngeal nerve from the carotid and vagus nerve from aortic bodies to our respiratory center, which is located at our brainstem. These centers can be further divided into 4 smaller groups: the dorsal pons as pneumotaxic center, dorsal medulla as inspiratory center, ventral medulla for expiratory center, and lower pons for apneustic center. Based on the signal that these receptors send, the brain regulates our inspiration, expiration, its rhythm, and its rate. They do this by sending signals via the respiratory efferent nerves to their specific muscles, as we have seen previously, to carry out the action. We too actually have central chemoreceptors. They are very sensitive to carbon dioxide and hydrogen ions, but not oxygen. Although these are called receptors, though some authors prefer to call it chemosensitive area. We do not have an efferent nerve for it since it is located in the central nervous system. So let's put it as another factor contributing to our respiratory center. After all, it is called the integrating center for a reason. As you can see, this complete circuit reflects the autonomous kind of activity that this system has. In the somatic system, your reaction to your sensations are entirely up to you. For example, when in pain, you may scream, you may call for help, you may rub it off, or you may curse if your conscience allows it. Of course, there are few minor exceptions. For instance, if inflicted with pain, there is a reflex called the pain withdrawal reflex, which is a protective mechanism. But these two are limited to some degree because we do not experience such a reflex in all kinds of pain. Our lung also has its own protective mechanism. They are the stretch receptors located at the muscular walls of the bronchi and bronchioles that will detect overexpansion. When these occur, they will send signal to the respiratory center via the vagus nerve. The inspiratory center will be inhibited. Then signals will be sent via the respiratory efferent nerve according to the muscles affected. In this case, since inspiratory center is inhibited, the expiratory muscles are activated, hence expiration will occur. These reflexes are also called the herring-Breuer inflation reflex. Earlier, we also established that we can cough and sneeze. These are also autonomic reflexes due to presence of irritants in airway detected by irritant receptors in both upper and lower airway. Irritant receptors from lower airway send signal via the vagus nerve, whereas those from nasal cavity are sent via the maxillary nerve, both to the respiratory center. Then our centers send a sequence of muscular reaction involving the laryngeal muscles, the epiglottis and respiratory muscles according to these efferent nerves, and these will initiate a cough reflex. And a similar reaction occurs in sneeze reflex, but involving more muscles such as the uvula. Another muscle not included here are the facial muscle. That is because even though we usually sneeze with our mouth closed as to force the irritants out of our nose, we can actually voluntarily open our mouth when we sneeze, but that means secretions will be forced out from both our mouth and nose, so double the messiness. In the first video, we also mentioned that our respiratory system, other than breathing, it also involves in vocalization. We have also looked at all the laryngeal muscles and its innervation. So, is there a specific neuronal circuit for this? Well, actually, speech is an action that are controlled mostly by our nervous system, but only a small and significant part involve our respiratory system. Let's look at how our respiratory system contributes to speech. A speech production has three phases: the formation of thoughts, control of vocalizations, and the act of vocalization itself. Our respiratory system partly involved in the last one. The act of vocalization encompasses breathing, phonation, articulation, and resonation. The speech production process are controlled by different areas of the central nervous system, such as the Wernicke's and Broca's from Brodmann area 22 and 44-45 respectively. But essentially, our respiratory center controls the breathing to bring air in that is needed for a sound to be produced, and primary motor center approximates the vocal cord for phonation and controls the lips, tongue, and our soft palate for articulation. And lastly, resonation, which is passively provided by the air spaces in our respiratory system. So, is there another kind of circuit for speech pertaining to our respiratory system? Perhaps not, because we have seen how breathing works voluntarily and involuntarily, and the resonator chambers just exist as they are. That's it for now. We'll continue our last two components in part 3. If this video proved useful, hit the like button and share them with friends and family. Subscribe this channel for future videos. Thank you for watching. Bye bye.